And that's just there, and that holds you. Because if you put in, my belief is that if you put in just temporary sutures or dissolvable sutures in the repair, what can end up happening is that you haven't done anything that makes those edges heal together, right? You haven't cut them, you haven't created an injury. So you can expect that unless you're a patient who makes a lot of inflammation as you heal, that once that the strength of the suture is gone, that repair can open up again.
Okay, so because you're just relying on the scar tissue, correct?
Yes, and there can be minimal amount of scar tissue when you're not actually cutting that fascia or doing anything to it so that it needs to heal.
Okay. Oh, yeah, I see. Okay.
I don't ever use mesh. I have never used mesh. I have never needed to use mesh. I think that, in my opinion, women are stretched out, and that's why they need this rectus. That's why they need the diastasis repair. It's not an issue of not having enough strength in there. It's that you went through a pregnancy and you got very stretched out, and you're stretched out, so it's not an issue of not having enough tissue to bring together either. Right. So I don't do mesh repairs. Having said that, probably the next tummy tuck I'll be in there and say, oh my God, there's a hole here, I have to do a mesh repair. But in 25 years of operating, it hasn't happened yet. I'm not really expecting it to. I close the skin also in multiple layers, because when we think about what makes a scar look good, besides the fact that there's great, again, genetic variability in how people heal, we want there to be no tension on the skin edge. So whatever deeper sutures we put in should bring the skin edges together, so that whatever skin suture is the final layer is really not under any tension at all. So I do a repair, and in here I do use absorbable sutures, because remember, we've cut everything, right? So it all has to heal. It does not need the tensile strength of a suture material to hold it together long term. So what I do is, do you want the names of the sutures? I'm happy to do. I do a larger absorbable suture on what we call the superficial fascia system. So it is a discrete thin fascia that's in the abdominal wall that is between the two layers of the fat. And that has a lot of strength in it. So I put stitches in that interrupted, meaning, here and there. And that kind of starts pulling the abdominal wall together. And then I use another quill, but an absorbable, and I close the subcutaneous in one layer, and then I close the skin in a second layer. So I leave all absorbable sutures. I hate picking sutures out of patients. I try to never have to take sutures out of anybody, except in the eyelids. We don't leave absorbables in the eyelids. So you probably are aware that some people are doing drainless tummy tucks and things like that. I don't. Okay. The drainless tummy tuck is done because you put all these deep sutures in to kind of tack the abdominal wall down to the fascia where you've lifted it up to do the tummy tuck. And that can, number one, significantly increase the time of the operation, the time that the operation takes. And that's never without potential consequences. Okay. Number two, it can constrict blood vessels, right? You can end up catching all those extra sutures in the abdominal wall, which has already had part of its blood supply divided just by having elevated, lifted the flap. Right? That make sense? Okay. So you divided all the deep blood vessels that come through to the skin straight up from the abdominal wall. And now you have blood supply coming from around the sides. If you happen to put those stitches in an area where you catch one of those blood vessels, you can compromise the blood flow. Also, there's a delicate balance between having the two layers which you've lifted apart from each other stick back down without being stuck with sutures together, so that every time you move, you're kind of tearing on things. this is my belief. The drains go, I do a row of sutures right in the midline from the breastbone down to the belly button, which helps take tension off the closure down below. But it also helps create like a median raphe, because most women will have, before surgery, a line in the midline where there's a little bit less fat. And one of the marks of having a surgical abdomen, in my opinion, is if everything's totally flat after the surgery, because that's not what is naturally appearing. Okay, so I do put those central stitches in. I put in drains, and the function of the drain is that once you've done this surgery, you can leak fluid from the cut area, the same way as you get a blister and there's fluid inside that blister. What you want in the first couple of weeks after surgery is for those layers to stick back down together. If you're accumulating fluid in between those layers, then you lose the opportunity for the layers to stick. So the drains take that fluid out in the first couple of days. I find that the drains need to stay in usually 2 to 3 days for the first one to come out, and the second one comes out 2 days after that. Okay. In almost 100% of cases. So I explain to patients at the consultation, if they come in and say, I want drainless, I explain why I prefer to do it with drains. It just makes more sense to me. It's less pleasant in the first couple of days, but the whole operation is not pleasant.
Yeah.
So
yep.
we really want to do things that keep you safe and make the healing as unlikely to go astray as possible.
Right. I'm so glad you brought that up, because it's so interesting. So I had 3 consultations, and then I'm interviewing 3 different surgeons. And this is what I tell women when I said, look, you're going to go crazy because the surgeons all do it differently and they all have different philosophies. I said, you need to sit down, you need to listen to the surgeon. You need to figure out which surgeon makes sense to you and that you trust. And it's hard because, like I said, there's different ways to do it. There's the different sutures, like you said, drains versus drainless.
Right.
Asking about the closure. And I'm glad we brought that up with the scar. We didn't get into that in my other interview, but, wound care is often very underplayed. And afterwards, how there's different ways people close, I guess. Right. And I know some of it's just genetically how you scar, right? So that's going to be part of it, but then part of it's the technique. So it's definitely something worth like going through, and like how you explain that very, very in detail, and going to a couple different surgeons and seeing what they say, right?
Right. And then seeing what you're comfortable with. So I'm not saying that my way is the only way to do it, but I'm always happy to explain why I've chosen this way as opposed to the variety of other ways to do it. And then you as a patient have to feel comfortable with what it is that's being discussed. And you have to feel comfortable that you're getting answers that make sense to you, because that is really the big thing. And so it hurts my heart to be on these websites where women can post questions and get answers from, various people in the medical community. And, I'm a week post-op and this is going on, and what do you think? And I want to say, go call your surgeon. I mean, I just, there's a reason they're not feeling comfortable talking to their surgeon in this post-operative period. And that's where the relationship comes in. So, I don't go home with my patients. I see them frequently after surgery. And I've been told by people who worked in my office, who have worked in other plastic surgeons' offices, that I tend to see people more frequently than anybody else. But I don't know what's going on at home, right? I can coach and I can guide, but I don't follow you home. And even if you're intending to do everything that you're supposed to do, we all know that patients hear much less than is actually said at any visit. And I can't predict who's going to be that person who's going to go home and do something like where I'm practicing keeping my face straight when they come in and say, oh yeah, I knocked, the kitchen cabinets out.
Right.
You're 10 days post-op and you took a sledgehammer and demolished your kitchen. She was a contractor. She could do it. She got away with it, but
Ooh.
you know,
Yeah.
right. So this is a very important relationship. It is probably the most important relationship you'll ever have with a doctor, because this is elective.
Yes.
And it's a significant operation. Any elective surgery is significant, but abdominoplasty, because it involves your entire core and your ability to sit up and lie down and roll out of bed and get, on and off the toilet or whatever else you need to do, it is so big. You have to have a relationship with a surgeon who you trust and who can trust you to do what you need to do.
Oh, best message. I just feel I see it, and I can feel it with women just kind of settling or not wanting to, I didn't get these questions answered, and then just never getting them. I'm like, no, I'm like, you need to call, you need to, and if you can't do that, then you need a new surgeon. Like, it's a huge problem. And it's advocating for ourselves, right? I mean, it's tiring, but you got to do it.
Right. And I would say too that, it's probably not all the fault of the patient. I mean, different offices have different systems with which, patients are managed and how the flow goes. And you might, see the surgeon first time in the OR and you came to them because your 3 friends went to them, and then you see the nurse afterwards. I do all my own consultations. And again, this may not be the only way to do it. I just do it because, again, this is a relationship that is going to get you through something or is going to fail you. And I want to do whatever I can. Yes.
So awesome. Love it. All right. Let's see. I think we hit most of that. We talked about how to find while we're on this, let's talk about other tips or red flags or advice that you would give people while they're interviewing surgeons. Things that you feel like women should always be asking that maybe don't always ask. Any kind of tips there? Or?
I think it's so individual, and I think one thing that is really important is to find out if the surgeon has other patients that are willing to talk to you. We offer that. Not everybody needs it. Yeah. I also think that it's important that the surgeon, that you choose an office where the office is comfortable with your visiting more than once. If you're coming in for a consultation, you're not retaining everything that's said. Yeah. This is scary. Other questions come up, and I always say to patients, let's do this. Sometimes patients say, I want to schedule right away. If they say, I'm just in the beginning of my journey, you're the first person I've seen, I say, you have to do whatever you need, but I can tell you other questions are going to come up. So why don't we have you make an appointment for another couple weeks just to come back in to check in. There will be questions, and let's move from there. Let's circle around again. Yeah. I think that most women are intelligent and should trust their own instincts and concerns. And if you don't feel comfortable, leave. There are other surgeons. Don't try to talk yourself into doing something that doesn't feel right to you.
Yeah. Awesome. All right. Okay, so we talked about the repair. Now, from an athletic standpoint, there's been talk about, you're bringing the rectus muscles together. There's talk of some surgeons overlapping those muscles, or is there a way to make it too tight where it would affect the muscle athletically?
I don't really think so. So when you do this repair, the muscles are all relaxed. The patient's given medications that the muscle are relaxed. And I think that there is probably some artistic level of input here where you know you're pulling them together so that they're in the right position and that you're still getting a nice cosmetic result.